I'm delighted to have these few minutes to encourage you to protect your patients with genetic testing. The problem I want to talk about is that even though cardiogenomic testing is a must for certain patients, very few such patients are sent for testing. Genetic testing is recommended for patients with cardiomyopathies, channelopathies, aortopathies, and family lipidemias. And this is true even if there is no family history. Also, of course, any heart disease that has a family history should also be followed up with genetic testing. But instead of everyone with these conditions getting tested, only 1 to 2% are tested. And a big part of the problem seems to be myths. So here you see only 0.8% of the people with dilated cardiomyopathy, a disease that killed in my family, are tested instead of 100%. So here are the myths that we have to overcome. First is that genetic testing costs thousands of dollars, when in reality, most patients pay less than $100, and often the out-of-pocket maximum for patients is less than $250. Another myth is that ordering and interpreting a genetic test is very complicated, but in truth, tests can be ordered and interpreted easily with company-provided genetic counselors. Sudden cardiac arrest only occurs in those with a known heart issue, but in truth, it can be the first symptom of a heart problem. It only happens to older people. Sudden cardiac arrest can affect people of all ages. And learning about a genetic mutation just causes worry. But in truth, learning about many mutations can lead to actions that save and improve lives. And when you talk to patients about this, it might be useful to compare genetic testing to getting a blood pressure test or a cholesterol test. A positive result is a warning that you can do something about, not a death sentence. Heart disease often results from an interaction between genetic and environmental factors. And indeed, almost 1 in 5 cardiomyopathy patients who have an environmental risk factor also have a mutation. So these patients with environmental risk factors also need to be genetically tested. So genetic testing can sometimes actually direct therapy. It can often protect family. So if the family members are tested, those that carry the disease-causing mutation can get early treatment. But of course, this is only useful if there's follow-up, clinical follow-up. Family members who don't have the mutation are reassured. Couples that want to make sure their children don't inherit the mutation can use pre-implantation genetic testing. But even if someone has the disease-causing mutation, they may not have the disease yet, and they may never show the disease. This is because of penetrance, and that's the chance that the mutation causes any effect in a given person. So I want to stress, even without showing any symptoms, a parent can give a disease-causing mutation to their child, and in that child, it may cause disease. If, despite a family history of disease, no mutation is found, you'll want to test again in a year or two when new mutations have been discovered, and in the meantime, continue clinical screening for first and second degree relatives, assuming that they have the mutation. So the take-home messages are: genetic testing can lead to early treatment and protection for the patient and their family. For example, protection from sudden death. Genetic testing is only useful if there is follow-up in clinical care, for example, more intense screening. Targeted testing is essential if a patient has a disease frequently caused by a mutation or there is a family history of disease. But family history is often not obvious because of penetrance and misdiagnosis. So I want to mention that I was motivated to speak to you today because of the 4 generations of sudden death caused by a mutation in my family. I tell this story and how it led us to find a previously unknown heart disease gene, FLNC, in my recent book, The Dressmaker's Mirror, Sudden Death, Genetics, and a Jewish Family Secret. Thank you so much for this opportunity to speak.